Hello, everyone. Thank you for joining us for this webinar. My name is Sarthak Das. I'm the Chief Executive Officer of the Asia Pacific Leaders Malaria Alliance. We are delighted this evening in Boston, Professor Jha, to have one of the most eminent leaders on global health, development, quality, and education with us to speak on COVID-19 universal health coverage and a new paradigm for global health in the age of the pandemic, in the age of pandemics, I should say. So I'd like to first introduce Professor Ashish Jha, Director of the Harvard Global Health Institute, Dean for Global Strategy at the Harvard School of Public Health, and soon to be the Dean of the School of Public Health of Brown University. Thank you, Professor Jha, for joining us.
Sarthak, thank you so much for having me on.
Yes, absolutely. It's really a privilege for us, and I understand how busy you are in terms of providing guidance and also speaking so widely on the subject of the pandemic and COVID-19, its impacts on health policy in the United States and around the world. And we at APLMA are so grateful to you for taking the time to speak with us. But the premise of this series, we are only as strong as our weakest link, it certainly applies to a wide range of the kinds of problems that we work on. And so the way that this is going to work for the 29 minutes that we have left is a back and forth chat. There won't be time for questions, so I appreciate all of you have taken the time out in whatever time zone you may be in to be with us for this time. If there are questions, email us at APLMA and we can send them to Professor Jha to take a crack at them.
Or you can have me back at another time.
Or we can have you back at another time. So just to dive in here, part of the point of reference for us is at APLMA, when we think about the progress that's been made on malaria in our region, we're at the precipice of eliminating a scourge that has been in existence for thousands of years. If we were able to attain a goal of regional elimination in Asia Pacific, we'd be talking about averting 123 million cases by 2030 and potentially having economic benefit of up to $90 billion. So how do we deal with challenges of sustaining progress towards elimination of malaria, towards confronting tuberculosis, drug-resistant TB, HIV, maternal and child health, I can go on, when something like a pandemic arrives?
So thank you again for having me on, Sarthak. And you were asking possibly the hardest question facing all of us in global health. So to say that I don't have a simple answer would be an understatement. I don't have a simple answer. But I want to think about this with you, and I want to think about this with everybody who's listening in. And so it's worth, I think, taking a minute to talk about where we are with the pandemic and why it is so disruptive. This is the worst pandemic we've had in a century. Since really the 1918 influenza pandemic, there's been nothing quite like this. And while only about 7.5 million people have been found to be infected, and about 400,000 people have died, the truth is we think the true toll of this disease is already probably 10 times higher than that. And so I suspect that we have probably 40 to 50 million people in the world who've been infected, and probably 1 million people or more have died of this disease. And we are very early in this pandemic. So when you have something this severe that can kill, well, officially 500,000 people in 2-3 months, there's no surprise that it is going to cause severe disruption to everything in our lives, including the most important issues that we all care about, that you care about, that I care about in global public health. Those are both infectious diseases like TB, malaria, HIV, There are the non-communicable diseases like heart disease and stroke that have become so common. And then there are, of course, things like maternal and child. On one hand, I want to start off by saying, I think to believe that somehow we could ignore the pandemic and continue our work in malaria, continue our work in TB is unrealistic. It's not possible. 2/3 of the world has been shut down because of this pandemic. The most important question for me as I have been thinking about this, or two, and I think they're both related, is we have a year and a half to go in this pandemic before there's a vaccine that's widely available. How do we continue to make progress in that year and a half? How do we not lose that entire time? Because it will take us a generation to catch up. And the second question is, how do we prepare for the next one? Because this is not the last pandemic we are going to see in our lifetimes. And so how do we make sure that when the next one arrives, it is not as disruptive as this one has been? Those are the questions. But I am not surprised that this pandemic has been as disruptive as it has. And it's hard to see when you have something this large, this dramatic, that it won't wreak havoc in all parts of our lives.
So, it makes me think about the fact that, and I was in Sierra Leone in 2014 in October in the midst of the Ebola outbreak, and spent a fair bit of time in Sierra Leone and Liberia thereafter. And I know that you were leading an effort with the London School of Medicine, Tropical Hygiene, and as well as the Harvard Global Health Institute. And there was a Lancet Commission, 10 Essential Reforms. Will Ebola change the game? And specifically, so many of those recommendations hinged around this notion of regional collaboration, global collaboration, cross-border collaboration. So in that, and that's certainly a parallel for us in what we're trying to do with malaria, but this has now been brought into such incredibly stark relief. What are some of the things that you think in terms of COVID-19 at present are working in terms of coordination or regional collaboration, and where do we need more? How do we do better at it? You were interrogating this 5 years ago, along with the leading experts of the world. And here we are.
Here we are. You know, Sarthak, so it strikes me when I think back to that time, and we made a set of recommendations about what WHO should do. We made a set of recommendations about how global health governance should be structured, how countries should invest. And I can go through the details, but at a high level, at a very macro level, what we were arguing for was global solidarity and regional solidarity. The idea that health, the progress for health was going to come from countries working together and countries making investments preemptively and proactively. And that the cycle that we had been in, the cycle that we often talk about as panic and neglect, that you neglect these issues until there's a large outbreak, then you panic, you put large amounts of money in, and then when it's over, you neglect it again. We were arguing that we've got to get away from that cycle, and that we have to look at the globe as a single community. We have to bolster regional efforts. One of the things I love about the Asia Pacific leaders' focus on malaria is it is a classic regional effort that we talked about as the kind of model we want for tackling complicated global public health problems. And what I would say is that there were too few of these that came about, that the investments that we and others called for didn't materialize. And WHO made some of the reforms that we argued for, but not enough. And so my feeling is this time around, WHO is performing better than it did on Ebola. It's been more on the front lines. It's been more vocal, more transparent, sharing more data, quicker to call a global public health emergency of international concern. But you know, we like to try to put all the responsibility on WHO and say it's their job to solve all these problems. I've always believed that you can't solve very many problems from Geneva, that you need to solve them from Singapore and from Delhi and from Jakarta and from Freetown and from Boston, that you need these kind of regional, local efforts, and WHO at best can coordinate. So then if you ask, well, what parts of coordination have been working well? There are some. WHO, I think, has been doing a very good job on coordinating clinical trials of medicines. WHO has been doing a very good job of coordinating clinical trials of vaccines. That's great. That you can do from Geneva. But the local on-the-ground effort of combating COVID is going to be a national effort, a regional effort, with WHO playing a helpful role. And I think in many parts of the world it is doing that. But of course it's facing an unprecedented pandemic, the worst we've seen in a century. And so we see countries around the world struggling.
Thank you. Yeah. And so when we think about regional collaboration, global collaboration, country level collaboration, one of the things that I'm keen to do, and I'm, for those who don't know me in our region, I've only started on May 1st, and I'm in the process of understanding what we do and how we can do better, more efficiently, in a more focused manner in terms of our mandate. But certainly one of the things that we need to do, and there was a Lancet Commission on this as well in 2019, is tackle the hardest places first. What do we see with malaria? Again, we see that the pockets of endemicity are in places like Papua New Guinea, are in places like tribal and rural regions of India. That's where we're seeing it. Whereas you have a country like Sri Lanka that achieved elimination with pen and paper, as one of our board members and a leading expert, Dr. Kamini Mendes, was sharing with me. So we need, as we do with so many of these other issues, to have an intensive focus on the most vulnerable, on the hard to reach. Now, what we're seeing, while the data is still sparse, and what I understand, and I'm sure you know this data better than I do, is that communities of color are by vast numbers disproportionately affected by COVID-19. I read one account that was saying 90% of deaths and 50% of all cases. I don't know, that was 48 states plus DC. I don't know exactly where we are today. But the question is, so whether it's COVID in the US, whether it's malaria, TB, HIV, the most vulnerable are disproportionately affected. And so we also, as we think about health systems, how do we, what's your take on the resiliency of health systems for the most vulnerable? Thoughts on from a policy point of view? And if you want to focus on the US, that's fine, because there's plenty that we can apply. But,
So I will say a few things, Sarthak. You and I have both been in global public health for a long time. And one of the lessons that we know is any stressor on the system, any disease outbreak, any financial and funding cuts, it always affects disenfranchised and underserved communities the most, right? That's a long-standing problem. And so what we have seen in the United States is, as you said, a vast majority of the people who've been infected and died are Black Americans and Latinos. Just in case you think it's a purely American problem, what we see is that Asians and Middle Easterners in the UK have had rates of infection and death that are much, much higher than white British people. And I think we're starting to see in India and elsewhere, it is in the slums, it is in the migrant workers, that the disease is really starting to take hold. And so this is not surprising. It is also not acceptable. And so then the question is, what do we do about it? We can sit here tonight in Boston, tomorrow morning in Singapore, and say, yes, this is terrible, we should do something. So what are we going to do? How do we manage it in this pandemic? How do we address it for future cases? Well, first, I do think knowledge is important, and explaining and creating broad understanding that it is always these groups that are always hurt the most, and we have to understand that and prioritize that. Second, it has struck me in many, many places that one of the major reasons this happens over and over again is because we lack data. In America, we didn't know that it was Black and Latino Americans that were getting infected at high rates until late in the first wave. And we didn't know because we didn't have the data. We weren't collecting the data. Same thing in the UK. Often when I look at India and look at Southeast Asia, the reason we don't know that minority groups are being harmed is because we haven't put in the data systems. So when we think about a resilient health system, it begins first by having data on the right groups and making sure that you know what's happening. And then the last but not least is there's a lot of talk about resiliency of health systems. To me, there are two aspects of that that are very important. One is focus. That instead of saying, well, we're going to try to make the health system work well for everybody, you can try to do that, but that means that the poor and the underserved will be left out. Is you actually have to make a conscious effort to say, no, we're not trying to make it just better for everybody. We're going to make it particularly work for vulnerable populations. We're going to put our energy and effort into that group. And the way you do that, and this is the second part, is you got to build trust. You know, when I think about what happened in Sierra Leone, where you were in 2014 in Ebola, and I ran a high-level panel with health ministers and religious leaders from each of these countries. And the one issue that came up over and over and over again is when Ebola hit the slums of Freetown, when it got to Monrovia, when it got to, it was about trust of those people with the health system and with the government. And if you didn't have trust, you could have the best health system in the world, you could make it free, anybody could access it, it could be really high quality, and nobody would come because they didn't trust it. And so my thinking on how do you really deal with this issue is you've got to focus on data, you've got to make it a very explicit priority, and you've got to build trust. If you can do those things, you've got a fighting shot at dealing with these vulnerable populations and really addressing these things.
Yes. So I really appreciate those points, and I want to build a bit and probe on the last one. So with regards to data, I think that it's I think data and thinking about capacity building and program management go so hand in hand, because what we also find on that implementation end of things is that data is weak in those places. But when we make investments over time to build systems that work for those people, for those who have the responsibility in the public sector for collecting quality data and doing it in maybe, maybe an app works and a certain software package works, maybe shoe boxes to know whether or not people showed up for their meds the next day lead to incredible outcomes. But solutions for managing data and using that data to refine your program needs to be according to where people are. And that is not in any way meant, it's not in any way meant as a trying to say that there should be a double standard. But it does mean that whether it's therapeutics, whether it's diagnostics, whether it's data, all of those things need to be integrated in a thoughtful way with those communities that we're discussing, those public sector actors. Otherwise, what we find is that the gaps remain because the quality is poor. And so I wanted so it's this issue of capacity building. I couldn't agree more with you about data. And so that's where what I wanted to also probe and get you to say a bit more, because I think this is something I've been really grateful to learn from you is, so great data, but data to what end? What are you measuring? And so if you could say a bit about, you talked about trust, but very interesting, and maybe this was a lead in to me to say to you, how do you get good data and build trust? You get it when you have quality. And could you say a bit about quality, the measurement of it and its role and so forth?
Absolutely. So, for me, as you know, Sarthak, I've spent 20 years of my life studying healthcare quality in the US, in other countries, and I've written hundreds of papers and done all this work. And for me, the moment I understood quality better than any moment I have in my life is when I was in Madhubani, which is the district town of Bihar, which is one of the poorest states of India. And this was about 10 years ago. So, you know, I had already been promoted to full professor, and I thought I was very fancy and really was an expert and knew all this stuff about quality. And I was visiting Madhubani because that's where my family is. And I was talking to an uncle of mine. And we were just talking about healthcare and health. And I asked him about the hospital that was in Madhubani at the time. And I said, what do you think of that hospital? My uncle, this is not actually even my real uncle. You know, in India, like there are lots of uncles. So this was like a distant uncle, not super well educated, not very. And he said to me, Ashish, nobody goes to that hospital because you go to that hospital and you die. And we were having chai, we were sitting and talking. I remember it was like 6 p.m., the sun was setting, and this light bulb went off in my mind. So here is a guy who knows nothing about healthcare. He's not an expert. He doesn't think about the difference between access and quality. We always say there's access and then there's quality. In one sentence, he perfectly captured issues that I had been thinking about for 15 years at that moment and had not really understood well, which was, so here was a hospital in Madhubani, and it was often empty because nobody went there. And nobody went there because they didn't feel like they were going to get treated with respect. They didn't feel like it was going to be safe. They didn't feel like they would get the treatments that would make them feel better. So did these people of Madhubani have an access problem, or did they have a quality problem? And you realize that distinction in that context makes very little difference. And of course, it was a local hospital run by local people, so there wasn't this issue of it's outsiders. The issue was, when they went, they didn't feel like they were treated with dignity and respect. They didn't feel like they were taken care of in a way that was safe. And they didn't feel like when people went there, they got better. And that's what he described to me when I said, tell me more. Those were the three things he said. And I thought, you know, hundreds of years of work, all these very fancy Institute of Medicine, National Academies reports, and he was perfectly capturing what is quality. Quality of healthcare, there are many fancy definitions, but the simple definition is when you go to a doctor, you go to a hospital, you go to a nurse comes to you, you want to be treated with dignity and respect. You want to make sure that the care you're receiving is not going to harm you. And you want to make sure that the care you're going to get has a good chance of making you better. If those three things are present, you're getting high quality care. If they are not present, I don't care what technology, what fancy machines, what fancy doctors, you're not getting high quality care. Mm-hmm. And that has been to me a guiding principle in how to think about these issues of quality. And for the world's poor, you know, there has been this, I think, very paternalistic view that many people in the world, in the policy world, have had, which is they think the poor people of the world don't know any better. And I always say, the poor people are poor, they're not stupid. And poor people understand, they have dignity, and they understand when they are getting bad care. They understand when you are delivering care that is below par because you don't think they're worth the care that they deserve. One of the people I have learned the most from in global health is one of your mentors and friends and heroes as well, and that's Paul Farmer. And one of Paul's sayings is he often talks about the bigotry of low expectations, the soft bigotry of low expectations. That we have had a long history of walking into low income communities and saying, well, we can't do for them what we would do for the wealthy. Let's see what's the minimum we can do for them. Mm-hmm. Mm-hmm. It turns out the poor people totally know what you're doing, and they don't want any of it. They don't want that. They want to be treated with respect. They want to be treated as equal humans. They may be poor, but they still want to be treated with respect and deserve to be treated with respect. Yeah. So in all of the health system reform stuff, that's what I always come back to, that idea that I learned initially from Paul. which is that core to any health system performance is about treating people the way we would want to be treated and treating them with fundamental dignity and respect and delivering the care you can.
Yeah. Yeah. Wow. Feels like my last question to you, I may not be able to top that. Obviously that is all core, near and dear to me, and it's been
This
part
is
of how
one of
you
the
and I
reasons
have
why
been
you and I,
connected. This is why we do this.
yeah, and I
And
was going to say, it's one of the reasons you and I have been able to,
yeah,
I think, connect is because we
yeah,
both deeply believe that.
yeah. I like to always say, we say, I always think about this phrase that, we should be encouraging, reaching for high hanging flowers and low hanging fruit.
Yes.
But that sort of, but just putting the poetry aside again, because I think that's also something that I've learned to use. The poetry is good, but get back to the data, or get
Get back
back
to the
to
bit.
simplifying where we should focus. So in the last few minutes, and again, this is not to put you on the spot, just a brainstorm. If we think about, okay, you said the other day we were speaking, and you said, this is not a pandemic. We are heading into an age of pandemics. At the same time, we're on a trajectory to continue whether it's 90-90-90 on the HIV front. Really good progress has been made in so many places on TB. Again, I'm focused on infectious diseases, but
It's okay.
as you know, even in the epidemiologic transition, there are all kinds of incredible things that have been happening in resource limited settings around breast and cervical cancer and so forth. So the question is, it's an age of pandemics. You're saying we're in an age of pandemics. There's going to be an. What kind of long-term investments should we be making? How should we be? What is a vernacular that we should be using? I mean, vertical is still, as far as I understand, it has a place, because if you
It
don't
does.
drive, you're not going to get to eradication. You're not going to
Yep.
you're not going to get to elimination. Forget about eradication. So in our case of malaria. So in the last few minutes, thoughts, long-term
Yeah.
investments we should be making moving forward.
Yeah, absolutely. Look, so let me explain why I think we're entering a age of pandemics. We've seen more and more international disease outbreaks over the last 30 years than we've seen in the 100 years before it. There are many factors, from globalization, environmental change, climate change, the rise of economic development of China, of Southeast Asia, of South Asia coming, all of that, and the economic development that we're going to see across the African continent, all of that is going to put more humans in contact with animals. We're going to see more transmissions, and then globalization is going to spread those viruses around the globe. We are entering an age of pandemics. I have no doubts about that. So what do? We have to think very critically about where are the investments in health systems that we want to make. We have to invest in basic surveillance capacity, in laboratory capacity. We have to invest more in human capital, but we've been talking about that for a long time. I don't think it just means training more doctors and nurses. In the age of technology, you can have community health workers, but all sorts of other health workers who can provide extraordinary care with the aid of technology. We have to be more creative about those kinds of investments. Those are broad investments. We need both broad investments and vertical investments. I do think, for people who say all the vertical stuff is bad because we should just invest in health systems, I say it is the vertical stuff that has brought the deaths of HIV down in Africa. It is the vertical stuff that has brought the deaths from malaria across the world down. It is the vertical stuff that has made progress on TB. So I think vertical is very important. It's vertical and horizontal combined. Yeah. Invest in that basic infrastructure, target specific diseases, and then build in enough flexibility into your system, enough capacity into your system so that you're able to respond to pandemics. I am just going to finish with a little bit of a cautionary tale about India. I'm looking at what is happening in India, the rising number of cases, the underinvestment in health, for decades, and I am deeply worried. And then I look at Southeast Asia. I look at a country like Vietnam. It's done extraordinarily well on this pandemic. Not because Vietnam is rich or because it has some access to a drug or vaccine that India or America doesn't, but because it has been intelligent in how it has made its investments. And so while I think we need more, this is to quote one of my former mentors, Julio Frank, while I think we need more money for health, we need more health for our money. We need to be much smarter about the kinds of investments we make and really think about how do we have a system that can respond to these pandemics and outbreaks. And I think it's doable. And countries like Vietnam, along with Singapore, along with South Korea and other wealthy countries, but even more middle income countries like Vietnam, I think are pointing the way of how to do it.
Yeah.
And I think we have a lot to learn from them.
Gosh, great. Couldn't agree more. Thank you so much, Professor Jha, for joining us, and
always
looking
a
forward
pleasure.
to continuing the conversation.
I would
Thank
love
you
that.
to everyone who has joined us, and we look forward to hopefully having you at the next virtual Fireside chat. Take care.
Bye-bye, everybody. Thank you for having me on.
Bye-bye.